All right. Now, what if the deformity is like this? Any change in your plan or what if your fracture is like this, and what deformity are you at risk for? Now we're going up the shaft a little bit more to the proximal tibial shaft. What do you guys think about this kind of case here? This is obviously a segmental high energy fracture, but has the proximal component. What there's obviously things you need to worry about here, and I think it's important to for the rep to know that this is a largely or a very different animal that you're dealing with in terms of complexity. Do you agree?
100%.
Because we don't want to end up like this, Jan. Jan, you had sent me these slides. What do you not like about this case?
Yeah, so this is a different patient, but like you can see here, with a proximal third, what we're always worried about is valgus alignment, and this is something you just don't want to end up. Someone just put a nail here. I mean, you can see, a couple different errors just right off the bat. This is where their starting point was. You can kind of see where there's like grayed out area. So their starting point's really medial. It's not reduced. And so it ended up in valgus, and there's also an apex anterior deformity as well, but this was just impressive. So this is something you want to avoid for these proximal third fractures.
Yeah. Yeah. These are challenging. Now, suprapatellar nailing seems to have helped some of these deforming forces. I'll highlight some of these deforming forces really quickly. I don't want to get overly lectury, but on the medial side, proximal, you have the pes anserine that attaches. And then, distally, you have the anterior compartment muscles. And so what happens is you get them kind of pulling in such a way that it wants to pull that proximal tibia into valgus. And then, on the front and the posterior aspect of the knee, you have your patellar tendon attachment oftentimes. And then posteriorly, you have your gastrocnemius complex, which, spans across the fracture. And those opposing forces tend to want to cause a procurvatum deformity. So these are the forces that you're fighting when you're talking about a proximal third. And then not to mention that this is a much more metaphyseal region of the bone, so you don't get that kind of interference fit that you would get in the diaphysis. That the nail doesn't necessarily help promote the reduction of the tibia fracture. So you're kind of fighting all those things as you get into these cases. So, this is some of the issues when you start talking about starting points and how it can cause a deformity, of valgus deformity, as you can see here. Or if you're too far distal on your starting point, now it causes that procurvatum deformity as well. And you can see, when the nail goes in, how that creates that problem. So some of the technical pearls we're going to touch on here is, the suprapatellar is quite helpful for this. So that's one thing, making sure that start point's correct, and then using blocking screws to help manage it. And I'll show a case here of where maybe a blocking screw might have been helpful. And when you talk about blocking screws, Jan, how do you teach people how to use blocking screws? Because I think that's not necessarily a concept that is always very straightforward. It took me a long time, and I still have to double check where I'm going to put them if I'm going to use them.
Yeah. I think the simplest way I look at it, and when I talk to residents and teach residents, is you want to put the screw where you don't want the nail to go. So that's what, because they talked about the concavity of the fracture. You want to put on the concave side. I think sometimes that can get confusing, if we're not used to what does concave mean, what does convex mean. I think it's just easier if you don't want the nail to go somewhere, block it with a screw or a wire.
Brandon, any thoughts on how you decide where to put them?
Yeah, I would echo exactly what Jan said. I mean, the problem with thinking about just putting it always in the concavity deformity is that sometimes a blocking screw needs to go on the convexity of the deformity, right? Because depending on where the nail is. So if you look at this particular animation that you've got there, right? You can imagine when a diaphyseal nail goes, when the nail goes down into the diaphysis and fits inside there, it's going to be sticking out of the distal segment. It won't be able to move or change angulation in the distal segment very much because you've got interference fit in the diaphysis. But at the metaphyseal short proximal segment, it can move around a lot in there. And if you just drew a straight line that went right up the tibial diaphysis out the top of the tibia there, it would be traveling both two lateral distally in the proximal segment and two medially proximally in the distal segment, right? So you would potentially want to put a blocking screw medially on the proximal end of the proximal segment and laterally on the distal end of it to correct both of those deformities simultaneously, the rotational deformity of the proximal piece simultaneously.
What do you use for blocking screws? Are you using wires? I hear people talk about using wires. I hear people talk about using screws, drill bits. I've heard people talk about using that. What do you all have on your back table?
Yeah, I think I have all the above. Many times I'll just use a drill bit because a drill bit is easy to put in. And if it's like not far enough, if it's too far, if it's not in the right spot, you just take it out. And then I'll exchange it later if I need to with a screw.
Brandon?
I do the same, yeah. Same thing.
All right, I'm asking for a friend. How do you know, how far do you put that blocking screw? Say you're putting it here in that proximal short segment, metaphyseal segment, and you got it on the lateral, aspect there. How do you know, how far over do you bring that blocking screw? How do you decide where exactly that should go? Because I've definitely put them in and either it didn't do anything or it made it so extremely tight that it was hard to pass the nail or the reamers.
Yeah. So in reality, like most of the time when blocking screws go in, for me at least, it's after I made an attempt at reduction and reaming or at the nail going down, right? So you've got the fracture that you thought was a decent reduction. You've reamed it, you've placed the nail and seated it distally or wherever. And then it's like, okay, well, that's not the alignment I want, right? And then you can just use that spot for where the nail is to say, well, I don't want it to go there. So I'm going to put a drill bit in that's going to hit exactly where that nail is. And then I know it's going to displace it. So, for instance, if you had this, starting point that you've got drawn in here where that was truly reamed through the proximal segment straight down the shooter like that, and then you put the nail in there distally, and I'm drawing a very not straight line there, but it was straight down the shooter, then there, it would be perfectly aligned, right? But in reality, usually what happens is like where that second yellow arrow that I've drawn, or I'll draw another one here in red maybe, it's like this, right? You've got the nail down the entire segment like that, and it's out the proximal segment in this area where you don't want it to be, right? So then you're like, okay, well, I'm going to put a blocking screw where I don't want that thing to go. So I'm going to put one here that's going to hit the nail, and potentially you might put another one there where you don't want it to hit the nail. So you can move the nail over where you've got it, where that black line is, right? So I would put the drill bit in, I'd hit the nail with the drill bit, pull it back with the guide wire in place, then put the drill bit through the posterior cortex, and then either pull the nail and re-ream it if you think you need to, or just put the nail right back down if it's cavernous and wide open.
Yeah, that's a good tip with the, just put it in and then not pass it through, because once you pass it through, you kind of burn that hole, and it's hard to put another place just close to it, or another drill bit just close to it, because it's always hard to get another starting point started again. Jan, any thoughts or tips on those?
Yeah, I do similar. I mean, I kind of look where it is. I'll place the nail or guide wire too. If I notice that my guide wire is not where I want it to be, and I'm like, okay, this is going to be a deformity, I'll go ahead and do it then, even before I place the nail. I'll put a blocking drill bit, but not put a screw right away, because I can then adjust it, fine tune it if I need to, because I've done the same thing. Sometimes I'm over aggressive or not aggressive enough, and it depends on the quality of bone too. So you can't always get what you want, right? Sometimes you just have to know, you might be being too aggressive.
Yeah.
So here's a question. So you all spoke about fixing the distal fractures first, then throwing in the nail. Are you utilizing mini frag plates to help provisionally reduce your fractures before doing the definitive nail for these more proximal fractures or mid-shaft fractures? And I'll let you, Brandon, are you using mini frag plates?
I do occasionally, but I think, as you pointed out in your comment too, you got to figure out exactly what the biologic cost is of each reduction maneuver you're going to do, and that to me is near the top of the ladder, right? Opening it and plating it. So it wouldn't be the first thing that I would do. I would try closed reduction techniques, traveling traction. I saw you a picture up of that first. Blocking drill bits or blocking screws, clamps placed percutaneously first, And if you can't get any of that to work, then yeah, sure, go ahead, open it and plate it. Especially if it's a very proximal pattern. The time where you're going to do that first, obviously, is if it's open, right?
Yeah.
It's open. I'm already looking at it. Then there's very minimal additional biologic cost to go ahead and use a provisional plate to hold the reduction.
Yeah, Roth, that's an excellent point. So if it's an open fracture, I'll always ask for a mini frag or small frag to be open and ready to go. Because I mean, like if it's open for me, that's like it's a gift.
Yes.
So
Yes.
I utilize it. So that's another tool you can bring to the operating room. It's not just the nail and so forth, but a mini frag or small frag. I think it really adds the case and just makes it almost like we'll say the term sawbones then, right? Because it's reduced, no one has to hold it. So it can be definitely a very helpful tool to have.
So this is just going to go through and kind of showing. I don't want to I want to make sure we have time for the cases, but here you can see use of a blocking screw posteriorly for a case like this, and it's always just like that. It just corrects it, just as simple as can be, right? But then to your point, Roth, here's a case of a segmental tibia fracture where they used a blocking screw. I think a blocking screw behind through the plate, maybe. I think Jan, this was maybe your case.
No, I took this from one of the articles, but this was you can this is a plate. I don't know if this is an open, but for these segmental tibia fractures, I think a lot of times it can be more. I find myself sometimes even opening them proximally just because of the the large metaphyseal area that you have proximally. You can't get control always with a clamp easily. So these sometimes I've opened and then done a plate, and someone just mentioned that the plate nail combo. So sometimes there might be even an articular split here that you can fix at the same time, or tibia tubercle with the plate, and then close reduce the distal part of the fracture.
Yeah, so this is that case, going back to the case, Jan, this is your case, I think, that you had revised of that valgus deformity of a proximal third tibia fracture. And it looks like you used some blocking screws to help correct that deformity.
Right, you can see that this is a lateral based screw to really prevent that valgus deformity that we saw earlier. Basically, so you think about it, the nail was going laterally, so this is blocking the nail from going laterally. The other way to think about it, some people will say, is that screw basically creates a cortex. So it narrows that metaphyseal segment for you. And as Brandon mentioned, sometimes you put a medial and lateral screw or blocking screw, just really to make it a much more rigid proximally.
Can you, any tips from both you guys, if you have the revision situation, or if you place your pin and you open the proximal tibia, what do you do if the start point's less than ideal, like as maybe in this case? Are you just hosed and you just take it, and then you're using blocking screws to help guide your nail through the proximal segment?
You hope that it's way off, right? Because then you don't, it's a little easier to make a new pathway that's not going to run into the old one. But if it's off by a relatively smaller amount, you're right, it can be very tricky to correct it, like half, 5 millimeters, half the diameter of a typical tibial nail or something like that. Because you can make a new starting point and put the wire over there. When you ream it, the reamer is going to want to go back to the old place, and putting blocking screws at the very end of the proximal part of the tibia, way up there, you can do it, but the bite of those drill bits or screws in the bone is not as good, because the bone, it's all metaphyseal bone, it's not going to hold as easily. And so it can be a little trickier. And sometimes then you need to do something different, like go to a plate or something else to hold the reduction.
Yeah, and someone mentioned here again, about nail plate combos, why are these becoming more popular? So I guess, Brandon, are you using nail plate combos for some of your tibias now?
I'm not doing it necessarily for something that I wasn't doing it for, a few years ago. Meaning, like, if you have, or I'm probably it's the same thing that you're doing it for, Jan, I'm guessing. But if you got an actual plateau fracture, like an impacted plateau fracture, where there's articular impaction or comminution, then I use the plate for that. And then if there's a diaphyseal or a metadiaphyseal fracture below it, then that really needs a rod. Then I'll use the rod for that, and the plate for the proximal tibia fracture. But for most extra articular tibia fractures, I think you can get pretty good fixation with a plate, a proximal tibia locking plate, or you can use a nail for it. And I'm not usually finding that I need to use both of them for the same fracture, same extra-articular fracture.
And I agree 100%. I think, if I'm using a nail plate combo for the tibia, it's usually because I'm dealing with two injuries, almost like I would say plateau plus shaft, and I'm trying to fix them together with the best implant for each one. And then someone also had a question here: any reason to go after that butterfly fragment? So in this case, when you're nailing these fractures, you're actually not exposing that butterfly fragment on the lateral side. So you want to keep the blood supply here basically untouched. So in this type of case, like Brandon mentioned, you want to try to minimize your soft tissue insult to that area. So as long as the length, alignment, and rotation of the tibia is correct, you can kind of just let that float in the wind and it should heal. Sometimes it doesn't, but most of the time it will.
All right, I'm going to move on. So this is that case kind of I showed before, the segmental tibia. And there's a couple of like good points here that I think, at least for me, were, good learning points. And I don't want to belabor this because I want to make sure we get to the distal tibia as well. But, when it's attached to something like this, where there's a large, medial wound, as oftentimes is the case, this is, I think, to Brandon and Jan's point, this is where using some of the mini frag plating is definitely a good option. And in this case, the initial, because I think a lot of times X fixes get used, but this was another strategy that was used, which was, 2 mini frag plates just to get it stable and get some soft tissue rest, basically. In particular, as you might imagine, there's a bunch of other injuries that are being managed between the pelvis, I think a femur, and some other soft tissue injuries that are like a neck injury. So, some things that can help be temporized in this case. Are you ever using this strategy instead of an X fix to help stabilize some of these fractures?
Yeah, for sure. I mean, this is particularly good for a segmental long bone, right? Because if you put an X fix or a periarticular long bone like this, that's also segmental. Because if you put a frame that's spanning from the femur, let's even say the femur is intact, right? No femur fracture, to the distal tibia, those intercalary segments, both the piece of the proximal tibia that's attached to the knee, as well as the segmental piece of the diapsis of the tibia, are going to just be moving freely inside of there. They're not going to be held reduced very well. So this is, you're going to be, if that's a photograph from this injury, right, you're going to be looking right at all of that. Yeah. And this will do a much better job of stabilizing it than an X fix.
So if you have this case come in when you guys are on call, what are you asking for? Are you asking for X fix and the mini frag, or are you just kind of using the mini frag to provisionally reduce it and then come back and fight another day and wash it out, wound vac, that kind of setup? Or what does that look like for you? If you're the rep and you get called, what would you want to have?
So I ask them for everything, because you never know when you get in there what you're going to need exactly. I have a plan in my head, but it can change at any time. So whether for this or an elective case, but I think, sometimes you could use a plate, and I'll use these damage control plates, but occasionally you still need to use an X fix if you need to add even more stability. So I think having everything in the room available, you don't have to have everything open, but just as another tool, I think could be very helpful here for these patients.
And what, in terms of infection risk, I mean, I got asked about what's the best way to prevent or mitigate infection. And I think the debridement is probably of the utmost important. As Tom Wiest, one of my partners, used to say, you only have one chance to have a good initial debridement. And so, very thorough debridement is important. Antibiotic beads, any other sort of like antibiotic devices that you're using for these cases. Obviously a wound vac is oftentimes being used, but what else do you have in your toolbox?
Yeah, so I'm using antibiotic powder for all these at a minimum, and then plus minus beads.
Brandon?
Yeah, I'm the same. I mean, not every open fracture will have enough space to put antibiotic beads into, right? And I would not recommend making space just to put the beads in, like, you know, jamming them underneath a soft tissue envelope that can't accommodate them. I've seen that before, right? Don't do that. But if there's an injury like that photograph you showed, that's going to have a lot of room to put beads into it as you loosely close that whatever's left of that soft tissue envelope after you debride it back around it. And I would have you're gonna be back on that, right? Yeah. So beads would be a great idea there. And if you don't have room for beads, then by all means put powder into it. That will help.
Yeah. All right. So now everything gets kind of quiet and taken back for definitive fixation. Here is initial start point. What do you think on start point? I mean, Jan, to your point, it's kind of, you just make it where it looks like it's going to go straight. It's maybe a little more medial than some of the other cases we showed, but it definitely looks great on that lateral view. And I think important to point out when you're getting this lateral X-ray that getting the a true view of the femoral condyles is important.
Yeah, so I will tend to, in terms of like here on the lateral view too, just as a for the reps in the room to help out like the residents and people maybe who are not as experienced nailing, is it's sometimes helpful to put something behind the proximal tibia to kind of give you an anterior force. Because so you
like
can
a tibial triangle.
Well, not like a triangle, just a small bump,
okay.
But it helps move that tibia forward. So because a lot of times, if you're putting a guide and if you're using a guide and not the wire by itself, it'll push you a little bit too anterior. And that the danger of that is you ream out the tibial tubercle, which is over here. And so you just want to be careful and mindful of that on the lateral.
Yeah. Is it too medial? I don't know. I think it ended up looking pretty good, but I guess to what we talked about is maybe a little bit more lateral. But I think Jan, your point was excellent that you kind of just line it up where it seems like it's going to want to go. And I think this actually looked, really quite good. I didn't have any major issues with that in terms of the start point. Jan, Brandon, what do you think?
Yeah, it's hard. On this one might be one where I think as maybe Jan said earlier, it's like the start point is recommended because it's supposed to be directly in line with the diaphysis, and that's what you really want actually. And not everyone's tibial spines are in the same spot in relationship to their diaphysis. So this one where I don't have a whole lot of fluoroscopic markers for where the diaphysis is supposed to be, I would have a low threshold to get if they have their other leg available, to get a fluoro shot or even a spot shot of the other side to see exactly where the diaphysis is supposed to line up with the proximal tibia. And then you could have a really good idea about where that nail is supposed to go. Because this fluoro shot, it's hard to tell in this one shot, but you're right, it does look a little medial. It's kind of going towards the medial side distally. That looks like the reduction might be in some varus. And so I'm not exactly sure where it's going to, if it's in the right alignment or not based on that one fluoro shot. And I don't know that you could get that information, without a flat plate or getting an x-ray on the other side.
Yeah. And I don't think I included it here, but I had a CT scan and I should have included it, but there is a lot of comminution. There's a lot of devitalized fragments across that anterior aspect of the tibia, which I think makes it a little bit difficult to tell where the diaphysis is. So it's distal, I think it looks pretty good. Not the best lateral. I think they didn't save a good lateral, but you can tell that the ball tip reamer is just in the kind of that lateral side of the tibia distally. And then you're kind of going forward with reaming, measuring. And, I think that what happened here, that plate, they had to take out those screws because they were blocking the insertion of the nail. And then you can see you got a little bit of procurvatum or a little of that flexion of that proximal segment here. Is this a case where you take everything out and you put a blocking screw behind it? Does that help correct that in this case? And if so, what are your, I guess you kind of talked about this before, but you kind of put the drill bit in, find the far cortex, and then come back. And if you like it, go ahead and advance it. Brandon, Jan?
Yeah, I mean, and you can see on the lateral fluoro shot, it's some angulation, but it's almost mostly translation more than angulation, right? That you've got going on there. So I think about it, this way. It's like, where would you want to put your thumb on this thing to make it reduced? And that would be on the front of the tibia, right? You'd be pushing that front part of the tibia down to make it reduced, because the nail is stuck in the diaphysis distally. You can't move the nail it's stuck in relation to the distal segment. You're just moving the proximal tibia around it. So I'd put my thumb right there to push it back. And then I think, okay, well, once I've done that, then where can I put a screw to keep it there? Because the nail is going to be in place. And in relationship to where the nail is currently sitting, that screw would sit somewhere here. In relationship to where the bone is currently sitting, that screw is going to be somewhere more like there, right? The more anterior circle that I've drawn. So I wouldn't, of course, make them right over the interlock, right? Because you might just go right into the nail, but you would probably put it, I'm ballparking based on the amount of displacement in the back of the tibia there. But somewhere in that general vicinity is where you'd probably start that drill bit, and then hit the nail, take the nail out, put the drill bit the rest of the way through, confirm you're on the correct side of the guide wire, right? That you didn't end up on the anterior side of the guide wire, which would be terrible. And then re-ream it and put the nail back down and see where you're at.
Yeah, these are really good tips. I hope you guys are writing these down, because I think these are going to be super valuable for you as you get into some of these cases. So that wasn't done in this case, but let's talk maybe a little bit. Let's say I should have done that. But let's talk about fixation of the proximal side. When you have these proximal third, you're using all your proximal screw holes. I mean, if it's 3 or 4, I'm assuming most have 4 now for a proximal third tibia fracture. Is that what you guys are doing?
Yeah, I'll use all the fixation possible proximally, because this is also metaphyseal bone, so you're not getting necessarily great bites from these screws. So I think it'd be I fill it up.
Yeah, Brandon, same.
Yeah, same.
Yeah. And then the follow-ups, and this has yet to be kind of played out, in terms of what's going to happen. But you can see there's a big bony defect, which probably accentuates a little bit of the deformity as well. But I think if I was going to do this over, I'd probably put a blocking screw there, like Brandon said.